Hello everyone, this is Chadi Alraies from SIF 2023. I'm very privileged today to be with Dr. M Lasala at SIF 23. John, thanks for being with us.
Oh, it's a pleasure. Thank you so much.
Yeah, so a lot of this meeting SIF has a full day of structural yesterday, today is coronary, but every time I come to SIF or any meeting, the structural heart just blowing up. Something new technologies and devices. So tell us a little bit about the TAVR for young or low risk patient, where we are.
Well, to your point, I mean, even for those of us in the field, it's hard to keep up with things that are moving this fast. But what we've seen, of course, is that some recent history that TAVRs have surpassed surgical implants. Mm-hmm. And that the age of patients having TAVR is dropping. And we think that those lines will continue to move at the same slope that they're moving at right now.
Yep.
So obviously that means that even though we've got an older population, younger people must be getting TAVRs.
Mm-hmm.
And we've got several issues with that, of course. They might outlive that, they may outlive it twice. So we have to be able to plan for that. We have to be able to go TAVR inside of that TAVR. And that means a lot of 3D modeling, making sure the appropriate coronary heights are there. Will they have an effective valve orifice that'll be appropriate for their size, their dimensions, to see if they can withstand that. And be able to handle things like what happens if there is a coronary obstruction. Can we get rid of those leaflets? Can we tear through those with a basilica or some other technology that might be forthcoming in the future?
Right.
So, this is an exciting time. Go one step further. Suppose we improve the resiliency of the leaflets to begin with.
So
we've got special treatments, of course, that Edwards has come out with basilica. But also there are some pure polymeric valves that may come out that may have the same durability as what would be expected for a mechanical valve.
Exactly, which is a good thing for young population.
Absolutely, it would obviate all the other things that we're worried about in somebody who's going to outlive the standard TAVR.
Yeah. So right now, what if somebody in the low risk young, who's, as you said, might live once or twice the valve, what's your recommendation?
Well, we have a sit down, of course, with the valve team. They talk to the surgeon. They're going to talk to the interventionalists. We give it to them pretty straight. The guidelines right now do not recommend it, say, for a 60-year-old. It's still a surgical implant first. If they're bicuspid, that comes into play. If they're unfavorable bicuspid, which would be somebody who has a calcified raphe or very dense calcium, we would most likely encourage them to have surgery at that point. But everything else being equal, we'll talk to them about mechanical valves. That's going to give them the greatest longevity, but they have to be on anticoagulation and they're young and maybe they don't want to do that.
Yeah.
We'll give them the lowdown on bioprosthetic surgical valves and going back in and putting a TAVR inside that. The longevity of those, of course, are pretty similar to what we're seeing with TAVRs, at least 8 years out. And then we'll talk about what the TAVR does. And, things being what they are, if a younger person is going to decide between a surgery and going home 5-6 days later and a longer recovery, and a TAVR where they can almost go home almost the same day or next day. Many people are going to favor towards a TAVR, particularly if they know that they can get another one down the road.
Is it a fair question that you have a one valve you go to all the time for young population compared to self-expanding versus bone-expanding? Yeah,
that's a good point. I think access into the coronaries becomes a significant issue, so lower seating valves might be beneficial there. It also does depend upon specifically the effective valve orifice in that person. What size valve will they take? If they've got a smaller valve area, it might be better to use a superannular valve for that person, just to give them less of a chance of having patient prosthetic mismatch.
Yes.
Now, for the most part, it probably would be a balloon expandable with those exceptions.
Right. So it's case-to-case study, discussion after the patient get turned down from surgery.
Absolutely. And of course, we all do our own specific things. We know what our biases are.
Yeah.
We try not to exhibit that bias because we do it together and let the patient make the decision.
Well, thank you so much, Dr. Lasala, for your time.
My pleasure. Thanks so much.
Yeah, let's watch this video and others on SIF Conversation. This is Chadi Alraies from Scottsdale. Thanks a lot.
Thank you.